RetinaRounds, episode number 188, Dense Vitreous Hemorrhage. Today's case comes from returning guest surgeon Dr. Ramon Bringe Freitas from Vila Velha, Brazil, at Evangelico Vila Velha Hospital. His patient is a 48-year-old diabetic patient presenting with light perception vision, a dense vitreous hemorrhage, and a tractional retinal detachment. The patient underwent phacoemulsification with lens implantation and anti-VEGF injection 1 week prior to vitrectomy. We discussed the management of complex proliferative diabetic retinopathy, pearls on surgical visualization, timing of intervention, and intraoperative decision-making. Thank you, Dr. Bringe Freitas, for sharing this case. Okay, so this case has been submitted by Dr. Ramon Bringe Freitas, who's a returning contributor to RetinaRounds. His patient is a diabetic patient with a dense vitreous hemorrhage, tractional retinal detachment. And this case demonstrates how to elevate the posterior hyaloid in these complicated cases. This patient's 48 years old, has light perception vision, and actually had cataract surgery and an anti-VEGF injection 1 week prior to the vitrectomy that we're about to see. This patient had staged surgery, and we've talked about the pros and cons of doing combo surgery versus staged surgery. But Esan, do you want to kind of walk us through some of the pros and cons of each of those approaches?
Yeah, I mean, I think it depends on, if you're dealing with obviously a patient who's phakic, how much cataract do they have? If it looks like it's already, meaningfully contributing to their vision, it is a conversation I'll have with our patients. Depending on the etiology of the hemorrhage, then you start thinking about systemic comorbidity. So again, if it's a diabetic patient, how well controlled is their diabetes? What other kind of issues do they have? Severe hypertension, hyperlipidemia, kidney disease, et cetera. If it looks like it's a patient is potentially very ill and they always be that way, this may be your one chance to kind of make things as good as they can be. And sometimes in these situations, I can't even get this type of a patient cleared in an outpatient ASC setting, and they're going to mandate that the patient go to the hospital anyway. So we do it as on the outpatient side of the hospital so they can be monitored closely. So again, these are all considerations. Ultimately, it's something I'll have a discussion with the patient. We do quite a bit of combination surgeries. It's something that I offer. It's not something that I mandate, but if the patient's a good candidate for it, I don't see a particular reason why it would be not good. How about yourself?
Yeah, I think maybe part of the calculus in this patient's case is because the posterior segment pathology is complicated. It's a dense vitreous hemorrhage, it's a TRD. It's probably going to be a longer vitrectomy, and so I think probably the surgeons here were thinking, well, we don't want to compromise the view. Let's just take the cataract out, make the patient pseudophakic, and let that lens sort of settle into place. Let the cornea clear up if there is any corneal edema. So we'll have a better view into the posterior segment, but also with these patients with very dense vitreous hemorrhage, there's often a lot of dense anterior vitreous hemorrhage. And so, you can sometimes, at least I get sometimes concerned when I'm doing a combo case. I don't want to get too close to the posterior capsule. I don't necessarily want to do a posterior capsulotomy because I don't want to destabilize a recently implanted lens. But once the lens has been in place, usually those anterior and posterior the anterior posterior capsule fuses, sort of seals around the lens, and it's a bit more stable, in which case you can do a posterior capsulotomy at the same time as a vitrectomy. So I suspect that that's part of the reason why the surgeons elected to do it as a stage surgery rather than combo.
Yeah, I totally agree. It's like time is tissue in this case. Time is your view. If you're doing combo cases, you want to have cataract surgeon who's kind of quick and efficient. They can get the lens in there. We've talked about these things before in previous episodes, but continuous, nice curvilinear capsular rhexis, something that's covering over the edges of your IOL haptic. You don't want a rhexis that's too big or too small or decentered. I usually like to make sure our main wounds are, at least the main corneal incisions, has a suture in it at the end for when we're putting in our sclerotomies. And then it's not a bad idea to at least put in that first port beforehand so you have access to put in an infusion line and stabilize the eye if needed. But yeah, I think in this particular case, there's complex pathology back there. Even if you're doing the cataract surgery quickly, I mean, you're going to start, this type of an eye is probably going to start getting corneal edema, and your view is going to go downhill relatively fast. So if you want to preserve that for mostly the retina part and do it as a stage procedure, I think that's entirely reasonable here.
Yeah. Well, let's take a look at the case.
Yeah, so they went ahead and did the cataract surgery first, and they're coming back here. How far apart to do the vitrectomy?
That's right, about a week. So this patient
Yeah.
had both cataract surgery and an anti-VEGF injection 1 week prior to this vitrectomy. You can see that the corneal wound has been sewn shut. It's also always very important. Make sure to put a nylon suture through that corneal wound when those trocars go in. Sometimes even a well-constructed corneal wound can open up and destabilize the anterior chamber.
Before you start this, just it's just something to point out. Just notice the distance from the limbus for these trocars. And I just harp on it with our fellows just having consistent placement. I mean, obviously you're pseudophakic, so you can, if anything, cheat more anteriorly rather than risking going too posterior here. But I wonder if that infratemporal one is a little bit, potentially even past 4 millimeters.
Yeah, it looks a little bit posterior there. Well, let's see what happens during the case. So you can see the light pipe and
Good
cutter being
view.
introduced as 25 gauge vitrectomy, and they're starting in a way that you actually like to start your cases, which is just clear out the anterior vitreous hemorrhage. It's
This is nice.
cleaning out that hemorrhage to clear up the view, and um, looks like even you can see the posterior capsulotomy there as well. So,
Yeah.
having that lens, I think, implanted a week prior gives you a little bit more assurance that the lens isn't going to destabilize when you're doing these maneuvers. And so, this look how dense this vitreous hemorrhage is, and so how do you know if you're cutting through retina or not? What's your clue here?
I always say we're going slow. You're starting anterior, you're gradually working your way posteriorly. I'm looking for clues like retinal vessels. I like what they're doing here. It's kind of like teasing apart with the cutter. You're making little holes, and then you're basically, kind of breaking through. Here you got a breakthrough here, almost like ochre hemorrhage or membranes that are here. And so this is kind of your clue here. Everything behind that is going to be retina. So you can start to kind of really clear out the rest of this stuff. But the
Yeah,
key is just go slow.
yeah, I completely agree. Looking for vessels is important. Once you pop through, aspirate some of that old subhyaloid hemorrhage there, so you can see your retinal landmarks. You can see some of the retinal vessels as they're aspirating that. I think also starting superiorly is important, so that if, heaven forbid, you get a break, at least it's in superior retina. It's a little bit less difficult to manage compared to an inferior break. And one thing that I've noticed, even with small gauge surgery, is that you can get vitreous incarceration in your trocar, especially with dense hemorrhage when it's really thick like this. And so the time when you're going to get that is when you're doing instrument exchanges. You can see here he's gone from the right hand to the left hand. And so what I always recommend for the fellows is to make sure that you clean around the trocar thoroughly before you're doing instrument exchanges so that you decrease that risk. One sign that you've got vitreous incarceration in your trocar is if you're trying to remove your instrument and it's stuck in that trocar, you're getting a lot of resistance. Don't pull too hard because you've got gel that's stuck in there. You want to just try to twist and clean around there, clean around the trocar as much as possible to relieve that traction. And sometimes even just pulling the trocar up over the shaft of the cutter is necessary, rather than just kind of pulling the entire instrument out and pulling vitreous and potentially creating an entry side break.
In line with kind of everything you said too, is one of my earlier objectives in these cases is to clear around the infusion port for that same exact reason.
Yep.
You have these thick blood and membranes, it could just basically block or clog your infusion line. And I've seen some of these where you're cutting and cutting, you don't have a great view, and your globe basically collapses too because you're not getting your infusion into the eye. So I am making an objective to at least identify the port early, try to clear around it, making sure the eye is being adequately irrigated.
That actually brings up another good point because normally when you put in your infusion line, you're looking to see whether or not that tip is actually within the vitreous cavity. But in a patient like this with a very dense vitreous hemorrhage, you probably aren't going to be able to see that. So, what are some tips that you have for surgeons to make sure that they're actually infusing within the vitreous cavity and not in the suprachoroidal space?
Yeah, if you're particularly worried, you can get a 6 millimeter cannula. You can have your scrub techs break that out. One thing I like to do though is if assuming I can't see the tip of the infusion line, is I'll introduce the light pipe through that trocar, And you can oftentimes tell with just the relative ease that it goes through, the kind of illumination it creates in the eye, kind of turn off the microscope light and put that in there. You can pretty much tell if you're in the vitreous cavity or not. Generally speaking, it's a good tip to use.
Yep, yep. That's a really great tip. So, as you have recommended, surgeons here are going nice and slow, kind of taking layer by layer, and not pulling on this vitreous. There are pegs down there, and so underneath this hyaloid face, and so you want to make sure that not to sort of trim back and segment and delaminate, just as you would any other TRD, rather than just trying to pull up on this posterior gel and potentially creating a
Doing a really nice
TRD.
job so far. Yeah,
Yeah.
not inducing too much unnecessary traction. They're isolating this tissue. They've cleaned up a lot of the blood so far, and I think some of the retinal landmarks are starting to come into view here.
So you can see that subhyaloid hemorrhage there. You can aspirate that. There you go, aspirating that hemorrhage, and now you can see your space is a little bit better to determine where you can actually introduce your cutter.
How
So
long
go
had
ahead
this
and-
been going on for?
I don't have that information, but it looks like this is a mix of old and fresh blood, so
Yeah,
it's probably been going on for a while. This looks pretty organized. Nice use of the
nice
forceps here.
feeling. Yeah, very
Elevate the
nice.
hyaloid there. Very nice. So now you can clearly see there's two different sort of islands. This infratemporal um, peg here that's going to be trimmed down, and then the area that's more closer to the optic nerve nasally.
Kind of
And
a tamponade agent, are you thinking?
I would just, assuming no breaks, I would just do air. I think that's fine.
What are your feelings on like a shakeout hemorrhage?
So I'll do a shave with scleral depression. So I'll try to get as much of that residual vitreous that's harboring hemorrhage out. Um, Anti-VEGF, if there's old hemorrhage in the residual vitreous skirt, anti-VEGF isn't really going to do anything about that. It's really just
Just
to
needs to
help.
seep out. Yeah.
Yeah, it's just going to come out. Now, whether a long-acting gas bubble, yeah, or even any gas, right? Whether it could be SF6 or C3F8, whether that makes a difference here, I mean, I think it's debatable. One of my colleagues, Hamid Hosseini, who we operated together at one of our county hospitals for a number of years, he really likes using a gas tamponade here for that reason, for the shakeout hemorrhage. What's your preference?
I feel like I like some kind of tamponade for no other reason. I think from my psychology and the patient psychology, they're prepared for it. You know, if I know I'm putting a gas and I'm telling them your vision's going to be really blurry with this in there for X amount of time, and I'm counting on the vision being kind of blurry. And if there is some of this shakeout hemorrhage, it's they have the gas bubble in the eye. I personally feel a little bit better with it there rather than seeing them at these post-op visits and it's just like dense heme everywhere and just waiting for it to clear out. When that happens, it's pretty annoying. It doesn't happen always, but
It does look like the retina is a bit elevated over here,
yeah, it looks a little
so certainly
boggy.
concern for a break. The patient's vision potential is quite poor. I mean, you can see how ischemic this retina is looking. And it brings up the question of, is it even worth intervening in these eyes? Patient's got light perception vision. We don't know what the fellow eye status is here. But
Yeah, I
what's your
think fellow
feeling
eye
on that? You
status
want to
plays a
give
big
give
role.
you want to give every patient's eye a chance, or do you have to make some difficult decisions sometimes?
I think if it's not unreasonable, I think the fellow eye status plays a huge role in this. What's going on in the other eye? Again, what's the time frame for this type of bleed? Like how long do you think the detachment's been there? But assuming the patient is motivated, that they want to at least try, and I think that they're systemically healthy for it without significant risk to them. I think it's worth trying. I'll always tell a patient, we'll at least try once. I think for some patients, just knowing that they tried, and even if they don't get the visual outcome that they want, they're not wondering kind of what if. It's easier for them to accept that outcome.
I completely agree. I think that it's worth a try. Even if, it's only, hand motions or counting fingers vision that's achieved. I think psychologically for the patient, knowing that everything was done, makes a big difference for them. I think it's also important, though, on the flip side, is to really, as you said, counsel patients so they understand that the visual prognosis is very poor and they're not going into it thinking, oh, this is the surgery that's going to restore my eyesight. This isn't like a dense white cataract and all of a sudden they're going to be able to see. The underlying tissue obviously is very sick. And I agree that fellow eye status is going to play a huge role in how aggressive you're going to want to be. And as long as the patient understands what the risks are and what the potential benefits are, I think if they'd elect to go for it, I'm definitely willing to
I've had
that journey with them.
patients, and you said this patient was LP before, right?
LP. Yeah, unfortunately, I don't know the patient's vision post-operatively. But I will say, I think that this was as well managed as it possibly could have been. I think this was a
Yeah,
really, really excellent
I'm gonna
surgery.
guess a patient potentially is hand motion to count fingers, and that is a jump. I mean, like I've had patients in that position, they will tell you subjectively their vision is much better. It helps with their peripheral vision or their ambulating vision, again, depending on the status of the fellow eye. Don't discount the impact, you get from letters vision, whether it's hand motion to count fingers, LP to hand motion. There's a lot that's going on in there, whether or not they're reading on the chart.
Yeah, and again, this case I thought was really well managed because it could go the other way very quickly, right? This could be an NLPI if it's not managed properly, and so kudos to the surgeons here for the
Yeah,
excellent.
they did a very nice job. Very nice technique in the back. I didn't really see any iatrogenic breaks. Again, they took their time. They meticulously worked at dissecting away the tissue, segmenting and delaminating, and all the textbook things we talk about. They handled that very well.
Thanks so much.
Thank you for sharing.
If you enjoyed this video, please visit us at RetinaRounds.com. There you can sign up for our email list. You'll get a notification every time a new video is posted. And if you have an interesting video or a tip or trick that you'd like to share, please follow the links on our website and you can upload your video there. Thanks so much for watching.